you for joining us today. If you have not already met Dr. Yoleetah Ilodi as our medical director here at Kendal at Home, and she will be discussing medications in older adults. But before she gets started, I want to remind everyone, if you could click on view in your top right corner and click on speaker view, you will be able to see Dr. Ilodi more clearly as she's talking today. Welcome, Dr. Ilodi. Thank you for being here with us today.
Thank you so much for having me, and thank you for your patience. I'm just going to put my screen on here to share screen, and I will get started.
Okay.
So medication use in older adults. So just learning some learning objectives. So we're going to identify normal body changes associated with normal aging, identify risk factors for adverse drug events in older adults, recognize adverse drug events. We call adverse drug events, a lot of times in layman's terms, we call them side effects. Recognize potentially harmful medications for older adults, and to utilize strategies to enhance the safety, effectiveness, and adherence of prescribed medications. So I want to talk a little bit about first why we make such a big deal out of it in terms of the cost. So the total estimated healthcare expenditure is about $7.2 billion related to inappropriate use of medications. So what does that mean, inappropriate use of medications? That means not just a mix-up at the pharmacy, but this landed someone into the hospital type issue, or it landed somebody into a nursing facility. 27% of adverse events in primary care offices, and when we say adverse events, again, same thing. It could be, I made a mistake and wrote you for the wrong medication. I meant to write you for this medication. I didn't look at your allergy list. I didn't notice that you were on this in the past and this was not effective, etc. 37% of adverse events in nursing homes. So again, there are several big issues with medications, and that's why I'm highlighting this this topic today, just to kind of discuss it in a little bit more detail. Most of us are on at least one or two medications, right? Even if it's an over-the-counter medication, an herbal or a vitamin, or it's a, Tylenol, a Motrin, we're on something that we take, some type of medication that we take. So some challenges of prescribing for older adults is oftentimes when you're prescribing a medication for older adults, they have multiple chronic medical problems. So when I talk about chronic medical problems, I'm speaking of things such as osteoporosis or arthritis. We can even start talking about maybe some a history of a heart attack or a history of a stroke. So they have multiple chronic medical problems. So when you're prescribing one medication, you got to take that into consideration. You also have to take in consideration that the person might have multiple medications from multiple prescribers. So if the person has a history of heart disease, they may see a heart doctor called a cardiologist, or maybe they see a neurologist, which is a brain doctor because they have a history of stroke. So now you have chronic medical problems, and now you have multiple providers writing multiple medications. As you see, it becomes, it's starting to become even more complex. Different metabolisms and responses, right? So how we metabolize medications when we're 30 years old is not the same way we metabolize medications when we're 70. Our metabolism changes, and the way that the medication reacts to our body changes. Adherence and cost. Adherence meaning, are you taking it? Some of us may not take our medications the way they're prescribed. We may take our Prilosec as needed, even though it says daily. Cost, that's a big factor. So I know for some of my patients who are on fixed incomes, that becomes very detrimental, that I try to get the lowest cost medication for them as possible. Also, I have a good amount of folks who take supplements, herbs, and over-the-counter drugs. And again, those have side effects. Those have properties that will interact with the prescribed medications. So you have to be careful of that as well. So some physiologic changes associated with normal aging. So I just wanted to talk about what our bodies are doing as we get older. So absorption. So just so that you guys know, we have less water, we have more fat, less muscle mass, we have slowed metabolism, for the liver, and then we have decreased excretion for the kidneys. And we'll talk about this a little bit more in detail. So absorption. So the absorption means like you take the pill, you take your pills. I don't have a pill. For some reason, I have a dry spaghetti noodle. It must be from my 6-year-old. But you can take so you take your pill, you take maybe 2 or 3. We don't know if those 2 medications interact with each other to decrease how much the medication is absorbed in your system. So this is my example. If you take Tums and you take an iron pill, the Tums will decrease how well the iron is absorbed, meaning you're not going to get as much iron in your system as you're supposed to get, if any at all. And that happens when you take multiple medications. You don't know if one medication is going to react to the other one, making it work better or work less. So distribution. So I try to break these terms down. So less water. So we have less water as we get older. So imagine a big bottle of water, a big cup of water, such as this lake. If I put a tablet, like an Alka-Seltzer in this lake, it's not going to disperse very well because it's so much water. So you have a lot of water that you're working with. But if I put this little Alka-Seltzer tab in this little cup of water, then, well, it's definitely a smaller amount and there's going to be more drug in it. So as we get older, we have less water, meaning it's going to take less drug to do the job. So, of course, less water, but more fat. So we have more fat, and guess where a lot of our drugs like to hang out with and get saved there? It likes to sit in the fat. A lot of the estrogen, our estrogen, for example, likes to sit right there in our fat cells and kind of slumber there, and it'll sneak out slowly. So we have to be careful if we have a fat-soluble drug. Again, we have decrease in metabolism, meaning if it has to go through the liver, it's slower, our metabolism is slower, it takes longer to break down that medication. Meaning that if I take a Tylenol, it may take longer for that Tylenol to work because it has to go through my liver for that to properly work. As well as we have an increase in interactions again with drugs. This here where I talk about excretion, and the short word for that is to urinate. A lot of medications, you kind of urinate that medication out after a while, but with aging, we don't urinate that out as much as we would when we're younger. And that hopefully that makes sense to you. That filter doesn't happen as quickly as when we're younger, and it sticks around in our system way longer. So now you got all of these things that happen in a normal, healthy body that's happening, And now you add on disease states, such as cardiac disease, kidney and liver disease, or neurologic diseases such as a stroke. And when I use cardiac disease, I mean something like a heart attack, or maybe you have an arrhythmia such as atrial fibrillation. Kidney or liver disease, maybe there's some cirrhosis, or maybe there's a history of kidney stones. And again, in neurologic diseases such as a stroke or Parkinson's. So 2/3 of older adults are on regular medications, as I said before, and adults age over 65 account for 1/3 of all prescriptions, 1/3, so 33% of all prescription, but only represent 15% of the population. And worse yet, and I say this all the time, when we do clinical trials, there's not a whole lot of older adults raising their hand participating in the trial. And a lot of them actually don't meet the criteria because most of the time they want healthy young adults on no medications. So my favorite is the Journal of American Geriatrics Society. I'm a part of the American Geriatrics Society, and they come up with this Beers criteria. And they do it about, I want to say the last one was 2012, before that was like 2009. So maybe every 3 to 4 years, they come up with a brand new criteria to discuss which medications are inappropriate for older adults and why. So to talk a little bit about the dangers of all of this even further. So the dangers of multiple medications. So we call multiple medications, and everybody defines it differently. If you Google it, you'll see all the different definitions of polypharmacy, but it is typically defined as someone who takes over 5 to 6 medications chronically. And why do we care about polypharmacy, meaning taking several different medications? Because again, those adverse effects, those side effects are cumulative. So if you take 5 medications that could possibly cause dizziness, you may have that side effect. Whereas if you were just taking one, you may not have that side effect at all. Drug-to-drug interactions, duplication of drug therapy. This happens quite a bit. So I will get a person who's in the office who's on a medication called Lasix, and this just happened the other day. They're on medication that was called Lasix, and it's a diuretic, it's a water pill. And then they came in the office and they ended up having some issues there. Nobody knew that person was on it because it was written by a specialist. And that person ended up having a duplication of medical therapy because nobody knew that they were on it. The pharmacist called it. The pharmacist called and said, hey, did you know this person's already on this medication? So poor adherence, meaning that maybe because of cost, somebody may not be taking the medications every day. I've had folks who said, well, I take my atorvastatin every other day because of the cost of the medication and decreased quality of life. So I call those social determinants of health. So if you're worried about keeping your lights on, keeping yourself in a home, keeping yourself fed, a lot of times the last thing a person is really thinking about at that point is their medications. And so therefore they have poor adherence. So adverse drug effects can lead to symptoms. So like I was speaking about the dizziness, or maybe it can lead to nausea or vomiting. Maybe it can lead to, it can almost lead to anything. A lot of times headaches. I hear that a good amount of time in my office. But it can also lead to not just the symptoms, but to poor patient outcomes. So if I am dizzy, then I'm going to end up falling. So it can cause falls. If you're so dizzy because of 5 medication, you can end up going to the emergency room trying to figure out what's wrong with you. Increased doctor visits or hospitalizations. If you're so dizzy, you don't feel like going anywhere, you don't want to go to the YMCA, you don't want to work out anymore, that can lead to functional decline. Perhaps because you're so dizzy because of the medications, somebody decides to put you on a medication to combat that dizziness. So now you're on 2 medications, one medication that caused the dizziness and another medication to take the dizziness away. That can lead to problems in cognition or thinking. And eventually it could lead to, in some situations, it can even lead to death. So the increased number of medications can lead to increased risk of what we call ADEs, which is adverse drug events. So ADEs, you get this no matter what kind of medication really you take. We'll highlight some medications that can definitely lead to this, but you can get this from cardiovascular medications. There's going to be always special cases, so I'm not going to try to name drop too many medications because I don't want you guys to go and analyze everything that you have. But again, if you're having some type of symptom, I would question the medication, especially if you just started on something new, a new medication. So psychotropic medications are like antidepressants. Of course, antibiotics can cause it. The biggest one I think of is Augmentin, and a big adverse drug event from Augmentin is diarrhea. And I guess I'll shout out just a couple of things. The big one for psychotropic medication is low sodium. Anticoagulants, and that goes without saying, that's like warfarin or Eliquis, apixaban. And of course, that goes without saying that can cause bleeding. So something you definitely want to watch out for. So NSAIDs, analgesics. So I want to just pause here and talk about Motrin, NSAIDs, what we call NSAIDs. Aleve, trying to think of what else that we put under that heading. You have to be careful because NSAIDs, i.e. Motrin, can affect your stomach lining, which can cause ulcers. It can cause heart issues, and it can also cause kidney failure. So even though this medication is over the counter, it can cause several different problems. So I just wanted to pause there just to say that. And anti-seizure medications definitely come with their side effects. And a lot of anti-seizure medications are also used for what we call nerve issues. If you have like a history of diabetes and have some nerve issues, we also use it in a psychiatric disease called bipolar disorder. So you're going to see the biggest risk factors of adverse drug events. Even though you can see this, no matter what, you put yourself at increased risk. If you have more than 6 chronic diseases, take over 12 doses per day. That's all together 12 doses. So not 12 medications, but 12 doses. More than 9 medications. If you're small, if you're over the age of 85, if you have some baseline kidney problems, and you have a history of side effects. So this is just more numbers. As you guys know me by now, I'd like to throw out a lot of data, just again, trying to highlight that this is definitely a true problem. 35% of community dwelling older adults experience this annually, and I really think that's an underestimate. 5 to 28% of inpatient geriatric admissions are due to adverse drug events. So what that meant is, so I was talking about dizziness. If that person was so dizzy that they came to the hospital and they were admitted to the hospital, and that's what that means. Two-thirds, which is 66% of nursing home patients experience an adverse drug event, and 20 to 40% of outpatients were potentially prescribed inappropriate medications. So those are pretty big numbers. So let's keep this in mind. I try to keep my patients' medications as short as possible. And I go over their medications every time they come in. And if I don't have time to go over their medications, I will pull one of my pharmacists to go over their medications. Or I will call their pharmacy to fax me a list of the medications that they picked up. At some point, though, I'm looking at their medications because this is a big deal. I question the need for new medications. I don't have to start a new medication on every symptom. I stop medications whenever it's possible. Maybe that person doesn't need the Tums anymore, or maybe they don't need the aspirin or the Motrin anymore. Then I stop it. I prioritize treatments. So I'm biased. So when a patient comes in the door, I have my agenda, they have their agenda, right? But I'm going to go with the agenda that's going to be most likely to harm them. So if my agenda is we need to get your cholesterol that is out of control under control, we talk about that first, and we'll move on to other things, but I will prioritize treatment and make sure that they're properly treated for things that can harm them. Weigh risk and benefits, that goes without saying. I avoid undertreating older patients, and that's important as well, because some docs out here may not adequately treat older individuals' pain or their blood pressure, or give them the proper anticoagulation, which is the blood thinner. So again, this is just a kind of the walkthrough. Does every condition need a drug? Maybe it's back pain, or maybe it's knee pain. I ask myself, is this benign? Is this condition self-limited? Does this condition bother the patient? Or maybe there's a what we call an essential tremor. Does this bother the patient? Are there alternatives for this? Can you decrease the caffeine? Can you exercise more? Can you eat better? Can you drink less? I mean, it really depends on the disease state that you're discussing, but you do ask yourself, is there something that can be modified in the day-to-day life? I ask about over-the-counter medications because, again, they will interact with the prescribed medications, and I especially talk about herbals. A lot of people feel that herbals and supplements, because they are natural, then they don't have side effects and they don't interact, and they most definitely do and will interact with other drugs as well with disease states. A big one is ginkgo, which interacts with warfarin, which is a blood thinner. We don't see as many people on warfarin anymore, but you still see some folks who are on ginkgo, and we have a tendency to make sure that we stop that so that it doesn't cause the blood to thin even more. I'll go back here. So I just like to throw out a case at the end here. Mr. Johnson is an 83-year-old. He has a history of benign, so we call it BPH, prostatic hypertrophy and hypertension, high blood pressure. After visiting his grandchildren, he developed a viral upper respiratory infection. He got a cold. He took an over-the-counter cold remedy containing a decongestant and diphenhydramine, Benadryl. He now comes to the office because he is unable to urinate. His blood pressure is 190/80. What happened? And this is where, if you want to put anything in the chat at this point and discuss what you think happened. So let's talk about what could have happened. So prescribing cascade, prescribing a new drug to treat ADEs. So this gentleman he just went and got some cold medicine, and he ended up with diphenhydramine, which is Benadryl, and a decongestant, which is phenylephrine. Those two medications, especially together, precipitated him to have what we call urinary retention. He couldn't pee. And so what that makes the bladder do is tighten up, especially on men, and they have a difficult time peeing because of that. So just because it's an over-the-counter medication doesn't mean that it's not going to have its side effects. So in this case, I would have loved a phone call, and so that I can let this gentleman know, Mr. Johnson, not to to stay away from those type of medications. Sometimes, not sometimes, always, if I have somebody who is on a new medication, not a new medication, somebody with a new symptom or a sign, I always blame the drugs. I say, what are we doing to them first? Because I never want to miss the opportunity to simply stop a medication that can be causing somebody some side effects that they don't need. And sometimes side effects can start at any place on the spectrum. Somebody can say to me, I've been on this medication for years. It can't be that. And that's absolutely not true. That, again, your body changes as you get older. So I usually would say, well, you haven't always been 75. And I know you say you've been on it for this long, but have you always been this old? Have you always had these medical conditions? Your body, even though the medication seems the same, your body has changed over time, and it's going to affect it differently. So Mr. Johnson arrives in the emergency department and is given meperidine, which is Demerol. And I also give the examples such as Narco or Vicodin for his pain. He is also very anxious, so he receives diazepam, or also known as Valium, which is a benzodiazepam. A few hours later, Mr. Johnson becomes very confused and somnolent. What do you think happened? So meperidine or opiates, these can cause confusion. This is a morphine derivative, and it's not, remember I told you, you urinate less as you get older. I know it probably feels like more, but the kidneys filter less. And so you have all of that just kind of all around your body, your body is holding on to it. It's not letting it go. And therefore, you have more confusion, you have more buildup. Diazepam, also known as a benzodiazepine, other words for it are like Xanax, Tenazepam, Restorol. Those are really not good for the body, especially on older adults. They're not good for anybody, but especially for older adults who are very sensitive to it. And approximately 50% will fall, and another 25% of those individuals will end up with some type of fracture. So again, the Beers criteria, which goes back 97, 2002, 2012, and 2015, we use this list on a day-to-day basis to educate patients as well as anybody in the allied fields on the importance of to not prescribe certain medications. We call it deprescribing, and we say less is best, especially if a person is as they're getting older. Other drug classes that can be possibly hazardous, again, are antihistamines, which are like Benadryl, some antidepressants, and anti-spasm medications and muscle relaxants. These medications can cause dry mouth, urinary retention, constipation, confusion, and delirium. So other drugs I just wanted to highlight briefly were the muscle relaxants, sometimes called Flexural. They're a different variety, but I kind of picked on Flexural here. Antidepressants such as the amitriptyline, some people are still on that. Antidepressants named like Paxil is a big one. Antipsychotics, diabetic medications such as glyburide, urinary incontinence medications such as ditropan called oxybutynin, antispasmodics such as bento. We don't use a lot of belladonna anymore. And antiemetics, especially Phenergan, can cause some confusion. So Mr. Johnson slowly recovers after his hip fracture. He continues to have some hip pain. So in addition to acetaminophen, which is Tylenol, his geriatrician prescribed those opioid analgesics for breakthrough pain, along with a laxative. Because anytime you have somebody who's on a narcotic, you want to give them a stool softener with that because it can cause constipation. His delirium slowly clears, and he is also able to participate in physical therapy. He's able to return home after rehab, which is the outcome we want. Before he goes home, his medications are carefully reviewed, including his over-the-counter medications. So again, just going back to the importance of reviewing medications at each stop and making sure that you take those hazardous medications off the list. So if you decide to prescribe, start one medication at a time. I know this doesn't always happen. Us physicians, we get really excited when we see something wrong and we want to start something. You know, I see your cholesterol is high. I want to start something for your cholesterol. And at the same time, your blood pressure is high. I want to start something for your blood pressure too. But we have to slow down. And, you know, I'm going to start that blood pressure one first because that's going to be the most acute one that needs to be treated as fast as possible. So start one medication at a time, and then maybe I'll start something else in a week. Start with a low dose and increase gradually. Monitor for response. And for Kendal folks, I would definitely say ask questions. So if you start to have a new symptom and it was soon after you started a medication, ask the question, could this be from the medication? And call your doctor. Monitor and anticipate adverse effects. Again, if I place somebody on a medication called Augmentin, then I want to anticipate that that person is going to have diarrhea. And assess adherence with a regimen. I want to make sure that the person's taking it, because if they're not taking it, there's no reason for them to be on it, and I'll just get it off their medication list. I'm very careful about the medications I pick. If it's a 4-time-a-day medication, I'm not prescribing it. If they're having multiple medications, I make sure it's with something that they can take, such as if they have thyroid medication, I know I have to tell them, take that an hour prior to your other medication. So I'm just very cognizant of the needs, the specific needs of each patient. Sensory impairments are important. So if they have diabetes, you want to make sure that, and they're injecting insulin, you want to make sure that their vision is okay so that they're able to use the pens or draw up the insulin or whatever they may need. If they have memory impairment, it's likely that they're going to need assistance with filling up their pill box. So just increasing, keeping it short, using a pill box. Reviewing medications, I review medications, I review expirations, as well as making sure that when you come to all of your doctor's appointments, bring your medications with you in a brown paper bag. So that is my presentation. Hopefully it wasn't too overwhelming. Let me kind of stop that. I'd be happy to answer any questions that you may have.
Thank you, Dr. Ilodi. If you have any questions, you can click on Q&A or chat at the bottom of your screen and type your questions in. It does look like there's one question so far. Can medication interaction changes happen due to anesthesia after surgery?
Absolutely. So anesthesia is the half-life of anesthesia is typically very short. However, every now and then, people can have a side effect where the anesthesia can make them more sedate. And then that mixed with medications such as if you're having surgery, you may need a narcotic like Norco or Oxycontin, or, you know, one of those, oxycodone. And so therefore it may even make you more sedate. Typically, again, it's a short-term issue that you have to watch for.
You make lots of great points today, lots of information, especially with those over-the-counter medications and those natural supplements that people take and really don't think twice that there could be any adverse reaction or interaction with those. Would you recommend then that, you know, if you have that cold before taking just an over-the-counter medication, at a minimum to check in with the pharmacist? If you're not able to get a hold of your doctor timely, just to run by what you're anticipating taking before you do it?
Absolutely. You bring up a great point, Marla, and thank you so much, because our pharmacists are our friends. I mean, they a lot of times will catch those medications errors faster than the doctor. Talk to your pharmacist, and they're not going to be as biased. You know, maybe I'm jaded, call me jaded, but some physicians, I'm not the type to say no herbs. I grew up on herbs. I'm not going to say no herbs, but you may have some physicians that say that, and that's not what you want to hear. You just want to know, what are the interactions? Okay, you know, keep the politics at home. What are the interactions? so you know, our pharmacists are great to go to, and they'll give you just that very succinct information.
Looks like there's another question someone's asking, is Versed safe for older adults?
So Versed in the case of surgery, yes. Versed at home, I've never had anybody being on Versed at home. But if you're doing like a surgery, it's fine, like a quick surgery.
Someone else is asking, they've been told to take a supplement, for example, vitamin D. How do they assess which brand? And of course, knowing these things are not regulated by the FDA per se, there's sometimes some, you know, specifics you need to be looking for on labels. What do you recommend in those situations?
So I usually go with, so you can go with some reputable brands. And it's not coming to me from the top of my brain right now, but I want to say, is it Nature Made? That's okay. I'm like, so I usually actually tell my patients to just get the Nature Made ones, because I know they have a triple check on those. But you're right, they're not FDA approved, and you don't know if you're really getting that much vitamin D. I can say, at least for the Nature Made, which is what I put my patients on, when I do levels for the vitamin D and it comes back higher, so I'm like, yes, that one works. That one has vitamin D in it. So when I check their vitamin D levels, it does come back and it has improved.
Dr. Ilodi, I was wondering, so many of our members have osteoporosis, and you were talking about the interactions with the Tums and all of that earlier. And I read something recently that drugs like omeprazole can, on high levels, or, the prescription levels, can interfere with the types of drugs that people would be taking for osteoporosis. Can you speak to that at all? Is that accurate? It's kind of weighing that people that struggle with acid reflux, but also have osteoporosis and are taking drugs for that. How did those interact with one another? Do they harm the effects?
That is a very good question. So when you take things, what we call a proton pump inhibitor, it decreases the amount of acid in your stomach. However, your body needs that acid for calcium to be able to be properly absorbed. So when you don't have the acid, now the calcium that you take is not properly absorbed. You have a decreased amount of calcium, and you have an increased risk of fracture. And that's what they're discussing. Now you do have medications like alendronate, which is Fosamax. We call those bisphosphonates. Those medications are nice because not so much that you want to take it with Prilosec or any of those other medications, but those can be injectables, and you often take those once a week. And when you're taking those medications, you also take them so far apart from your other medications because you have to take them 30 to 45 minutes on an empty stomach. So you take those medications by themselves. So it's not so much the bisphosphonates, but it's more of the calcium and the vitamin D properties because you need that acid to be able to absorb it.
Okay, thank you. I appreciate
You're
that.
welcome.
Don't see any other questions at the moment. But we thank you so much to consider when it comes to medications and interactions and their effects. So we appreciate you providing so much information for us today.
Oh, no problem. Just again, and if you're feeling overwhelmed by your physician, just tell them, slow down, pump the brakes, tell me about these side effects, talk to me, not through me, and just, tell them that you need to slow down. And it's okay not to start a medication. Say, how dire is it for me to start this medication today? If you walked in there and your blood pressure was 190, it's probably pretty dire that you get your blood pressure medication started. If it's because your cholesterol is high, and this is the first time it's been checked in like 3 years, and it's just, you could say, do you mind if you give me 3 months to see if I can get this down on my own? And that's okay. And so again, just have that conversation because your physician should be more or less your health advisor than a very, this is what you should do, but a person that you can come to and bounce things off of. So, well, thank you very much for having me.
Thank you. Have a good afternoon. Thanks. Thank you, everybody.
Thank you. Bye-bye.